Yeah, can we have 10 minutes for questions? Anybody? So I can start a little bit at first. I think Ken, I think you bring up a really interesting data sharing model, which has a lot of experience already. My question is, who owns the data? Is NCAS own the data?
How do I turn this on? Oh, should I take it off or just use it? Oh, okay. Thank God I'm director of informatics. I know technology. It's definitely not owned by NCATS. NCATS is the stewards of the data. And at part of the rules, the data transfer agreement is that anytime that you can take your data back. The only caveat is that if there's an investigator using your data and all use of the data has a year cycle, it's called a DUR, they get to finish their work because it wouldn't be fair to kind of pull the rug out from underneath it. But so nobody new can use it and we pull it out, but that we do ask that the institutions allow those investigators to use it because it just would be kind of cruel in the middle of their, but it's definitely not owned by us. Importantly, the NIH IRB though, in that tenant model, since the data is, from the NIH's point of view, a waiver of consent, we don't actually have to ask what the data is being used for. They consider it waiver of consent data. So whether it's used as for cancer or renal doesn't really matter to them. And which is really nice because we're trying to figure out ways to stretch our dollars, right? So a single contract, a single DUA, multiple types of studies, a single transfer, a single IRB. Transfer data once, used multiple times.
Jeff Barrett, Iridium. Ken, great talk, and thanks for exposing a lot of the dirty work behind the scenes. My question is on the topic of data use agreements and data collaboration agreements. Have you been able to get a common document, or do you have multiple flavors of these agreements?
So there's one data use agreement that I should remember the number, 392 institutions have signed. And there's one data transfer agreement that 84 institutions have signed. In COVID, we didn't allow it to be changed because we just couldn't. We have a new one that's coming out that NCATS is going to, I want to say it's almost not changeable. And the only caveat is there are state rules that we have to adapt to. And so there will be some configuration of the basic agreement, but the basic agreement can't really change because we can't do that. It's just impossible. It takes months and months and months to get these signed. So you can imagine our contracts office is 3 people. They signed almost 500 agreements in, whatever, 24 months during COVID. That you can't do that with 3 people. It's not scalable.
One follow-up question. You talk about the governance in terms of access and everything. Is that a steering committee? Is that one person? What's the complexity of who decides?
That's a good question. There's, again, within the any color but these three, it's really up to the data contributors because it's their data. And we're, again, just the plumber making it safe. It's in NCI's case, in the cancer tenant, NCI as a funder of it is also at the table making decisions. But generally speaking, it's just the data contributors. They can invite anybody they want. If you haven't been a data contributor, you can come in. But the data contributors are kind of controls because they're the risk, right? They're the group risking.
Well, Wilson, although the number is small, there was a measurable number where you couldn't, when you do the cleanup, you couldn't make them match. What do you do with those data, with those records?
Well, it's a complicated question. there's a semantic match issue, kind of this overall that we just don't understand. We cannot make this match. And we say unknown as the value, but every institution that gives us data, we give them a report card. We call it a scorecard. And it's about 70 pages. And it will say, this person, whoever it is, Mr. 1234, had a visit after he died. And so sometimes matches are fixable, and sometimes these are two concepts that just don't go together. We did have each of the common data models. They don't get along with each other. So we put them in 4 different glass rooms, and they could spit, but it didn't go through the glass. And we made them work out their differences of what is, where there's disagreements. So, and each time we do this, we go back and get tortured by them. So.
Creating a real world database, putting together a lot of real world data sets meets real world challenges. And I actually am part of the M3C pregnancy task force. And the challenges that we encountered were suggestive that there needs to be much more guidance before collecting the data, because we had to come up with algorithms to figure out who was pregnant and when they were pregnant, because it wasn't included. And we had to figure out algorithms to back calculate gestational age, which our OBs said should have been in every record, but weren't in most of the records. And therefore we had inferred pregnancies and inferred gestational age. And then as we were looking at the vaccination impact on pregnant women, we ran into this challenge, of course, because without having dates, we couldn't really back calculate the variants that were present at the time and had to make some course assessments. Now, we've done that, but I think when we're looking, and this group is looking at putting together very large heterogeneous data sets, there's a lot of planning that needs to go in very, very early, and a lot of heavy work for the adequate annotation, because the heavy lifting at the other end becomes extremely difficult. We actually had OBs who dropped out because of that. So.
Yeah, no, it's a really important point. And I'm not sure this answers your question exactly. The true dates are in 3C, and you can get to them, but you have to have an IRB. The de-identified, you do not. But they are there, so you could back calculate and match it to the CMS dates, right? So that was kind of a mechanical fix. But what you're talking about is more complicated. And as a physician, when I used to practice, you're just not going to get compliance from them. They're already overburdened and they don't see themselves as data entry people. And so if you're asking them to do a better job at data entry, or ask them one more required field, I would hide before you do that, because they're just not going to do it. The challenge, so we have so many challenges. One thing that's wonderful about the CADSR is we iterate over mapping. So each mapping is versioned, has a unique identifier, a GUID, an OID. And that's how we did it in April. But we changed in May, I'm making this up, because we found that there was a better way to do this. And so you as an investigator can point to a new data set, because we produce one every Monday, and you can choose how we did the semantic and syntactical mapping. That's not a great answer, but that's the best we can do.
Or Anita?
Thank you, Ken, for a great presentation. I love when people show up everything that we go through to get all this data together. So, but my question is related, you talked about the governance, right? It's important, really, the agreements are the important part. We don't have mother's data linked with baby's data, right? We don't have the mom and the kid's record. We don't have them online. And a lot of times, mom gives birth in one place, If the kid needs to be taken care of, they go to a different hospital, which is a pediatric hospital, has nothing to do with the adult hospital where mom gave birth. So where do you see those agreements go? Question one. Question two, a lot of pediatric care is done in ambulatory settings, which are not in general hospitals that contribute data to things like N3C. How do we approach those kinds of questions? Just wanted to hear your thoughts on that.
Is that Sean over there? Are you going to get me in out of trouble here?
That's John's question.
It's a really, well, you think the federal government would help with this, don't you? I mean, it would be so easy just to say, hey, there's got to be a link here that we can trust. I can go find those people. Rebecca Rosen's talking, I think at 3. Is she here? I think there has been a lot of efforts to do this. And, oh, Sean, thank you. I'm so glad your flight came in.
A couple of responses. There's a parallel between, for example, when we want to do cancer research, we often look for that SEER data set, which is a specialized data set designed for particular clinical concerns. Similarly, similar pattern, though not identical, we have every state in the country has natality data sets, right? And so I think if there's an opportunity to do maternal child real world evidence research at scale, I think we need to identify those regions, those states who have the ability to both combine their natality data with their clinical data. And I think that would go a long way because, there's no magic here. There's no, get out of jail free card. You need to find the right data out there in the real world to answer the questions that you're interested in. So that's just one thought that I would have on that. We're going to talk a little bit on the next panel, a little bit about some of the approaches that we're taking, even when you don't have that. But those are just a couple.
And I think we also, by triangulating, like we have CMS, and when we combine the CMS and the HR data, we're getting with 25% more, I'll say values, meds, visits, whatever. And I think as we combine the sets, and I'm also thinking we're working with hopefully Sync Health at Nebraska and iHigh on the next project, the cancer project that, from a state's point of view, and 40% of babies are born Medicaid right now, right? We actually are going to have that data. So I think there's another option, which is I'm really excited about, is that the HIEs, I mean, this isn't quite accurate, but wouldn't it be better for us to get data from 50 states instead of from 10,000 health systems across the country? Wouldn't that make a lot more sense, So it's not a perfect metaphor, but I that's one of the things that we think is going to really help. But it's inexcusable is the honest answer.
All right. We need one more question before we take a break.
So I know Dr. Winterstein's been online, and I wanted to ask her a question about working with the longitudinal nature of the data and how claims data may not work well with longitudinal data. For instance, we get prescriptions for 3 months at a time. So how do you incorporate the timing of taking a medication during the pregnancy into that aspect? So for instance, if someone's prescribed a medication 2 months before becoming pregnant, do you consider that as part of an exposure, or how do you account for that?
Yeah, typically not. Typically, we require a prescription filled during conception. And for that exact reason that you're describing, pregnancy could be planned. She may have decided not to take the day supply that she had originally been filled. And so that's the reason why we typically require a fill during pregnancy. In terms of the longitudinality of claims data, though, it's by far superior to EHR data. I think that's a really important part to recognize, because you have the move of a patient in the healthcare system based on anything the health insurance pays versus based on what is in a particular health system covered, right? So if you try to describe a new user of a medication, he might have been started by his PCP that it's not part of a network that is actually covered in the EHR data. You will never see that. That is the major reason why we use claims data typically as the skeleton of everything that we do, except for inpatient studies where EHR data obviously is superior. When, as was just mentioned, so we have the Medicaid data, the national Medicaid data linked to the to the birth certificate records as well as fetal death records of 3 states, to supplement the claims data again, because there is some information in there that the claims data would not have.
All right, let's conclude this session. We have more time to talk about the next section.